Welcome to Hi, I'm Ms. Sanchez, and welcome to Bio 105, video lecture number 3. This video lecture will be or will have the information that you will need for exam 2. All right, so first thing I'm going to do is go ahead and share my PowerPoint. And we will be working on with the PowerPoint that is under exam 2 content in your Canvas course. And it is the PowerPoint that is titled Biology 105, HIV and AIDS. So let me go ahead and pull up that PowerPoint, and then we'll go ahead and get started with our lecture. All right, so let me go ahead and put this in slideshow form. All right. So, situated. Okay. So when we talk about HIV and AIDS, this PowerPoint and this video, and then the fourth video, which will both be for exam 2, is very jam-packed with content. So there's a lot of content there. So on the first slide that we have here, this is actually a picture of an HIV cell or virus. And it tells you, and it just kind of shows you all the little pieces, okay? And all of this will make a little bit more sense as we're going through the different PowerPoints and stages and things like that. So first thing that we're going to do is just talk about a little bit of the history. Unfortunately, there's really no way that I know of to make history fun. It's just a lot of information, specific information about a time or about a disorder. And so it'll kind of just be going through that content, okay? And so the first thing it says that, HIV virus still remains somewhat obscured. What that means is it's really unknown, okay? And so we're going to talk about the history from very early on, but there's a lot that they still don't know. And then there's a lot of things that they're learning on a daily basis. So the earliest cases date back to 1959, and it was identified in the Democratic Republic of Congo. So, and it's established that HIV began to eradicate from its source around the 1930s. And what it means by eradicate from its source, it just means it started coming out of or from the source that it was in, kind of like it started coming out of its reservoir, right? So the HIV had to be in a reservoir somewhere. That virus came out and started to become known. Okay, so epidemic probably resulted from significant culture and social behavior changes. So what do they mean by that? So not remember, because a lot of y'all are young, but I remember I lived in I lived through the 80s because I was born in the early 70s. So I lived through the 80s, and I lived through the time of when HIV became prevalent in the States. And it was a very scary time. So the reason why they think that the epidemic of HIV began is because of, they say, cultural and socio behavior changes. So think about that, our cultural changes. So in the 80s, we started traveling more, okay? It was easier to travel. If it's easier to travel, people are flying more. You can go to, multiple states or out of the country in a day, right? Also, social behaviors, more unprotected sex, okay? There was still a lot of men who were homosexual, who were not open about it. And so they would be having unprotected sex with other men without using protection. And this is another belief of why it started spreading so quickly. The other thing was non-sterile needles, okay, for parental injections. So using sterile needles for every patient or sterile syringes per patient was not always the thing, okay? Also using contaminated products or products for medical treatments. So think about, remember we talked about in the first two videos for the exam 1 about sterilization, okay? So certain sterilization and disinfecting processes were not always in place. So HIV was recognized as a clinical syndrome since the early 1980s. The first case of AIDS was reported in 1981. And as we go through this PowerPoint, we're going to learn about what is HIV and what is AIDS, okay? So it is two different things, okay? So, so some more history of HIV. A 15-year-old boy, Robert R. in St. Louis, died from Kaposi sarcoma. And this is believed to be the first confirmed death from HIV infection in the United States. So Kaposi sarcoma is a rare cancer of the skin. And I'm going to show you a picture of that real quick. So this picture is also uploaded under your, well, maybe I'm not going to show a picture. Hold on one second. Pull that up. So these pictures, everything that we look at in this PowerPoint, I will let y'all know which pictures I have uploaded into your Canvas course. And those pictures and videos and things like that are all going to be listed under the content for exam 2. So this is a picture of sarcoma, the Kaposi sarcoma. So every one of these spots is a cancer. It's a tumor from that cancer. In the early 80s, before they knew a lot about AIDS and things like that, this was the first sign for a lot of people, or the way that a lot of people knew that someone had AIDS, is because they would have this Kaposi sarcoma. All right, so let's go back to our PowerPoint. Oops. Let's share my screen. Okay, there we go. All right, so when we continue to talk about, all right, there we go. So in 1987, the CDC reported 3 cases of occupational acquired HIV in healthcare providers. So occupational acquired, that means they acquired it while they were at work doing what their occupation was, okay? And it was, again, like it said, these were healthcare providers. So this is when standard precautions were developed to prevent the spread of diseases per occupational exposure. So this was to prevent exposure or you getting sick or getting this disease while you are working. So HIV is known as a zoonotic organism. So what does zoo mean? So if you think of zoo, you think of I mean, when I say zoo, I think of animals, right? I think, okay, I'm gonna go to the zoo and I'm gonna see animals, right? So what this means is that it's an organism that has been able to cross from animal species to humans, okay? So HIV can be in certain animals and it can be in humans. So There's feline HIV, okay? Felines meaning cat. So different cats, whether it's big cats or little cats, they do have a type of HIV that they can catch and will die from. So HIV began to spread in the mid to late 70s. Because of the long incubation period, the viral epidemic progressed undetected in many countries. So what that means in layman's terms, okay? So in 1970s is really when it started spreading, okay? That was the sexual revolution. A lot of people were having sex with a lot of different people, unprotected sex. And what was happening is that HIV was spreading. But as we continue to learn about HIV, that incubation period can be 5 to 10 years. Okay. So they would be carrying the virus, they could spread the virus, but they didn't know that they had it yet. So once the symptoms started showing, it wasn't until the 80s, okay? And that is why we started seeing so much of it in the 80s. It's because so many people had it in the 70s but didn't know, okay? So the virus began to cause widespread disease in the 1980s, again, because people had it in the 70s and they were spreading it, but due to that long incubation period, meaning that it's in the body, it's making viruses, but it's not showing any signs and symptoms of disease, we did not see it to the 80s. And it provoked fear among lay people, which is everyday people, and healthcare providers. And I'm going to tell you, I remember that time. Again, like I said, I lived through the 80s. It was very scary. There was so much misinformation, okay, that we were given. You know, we didn't have internet. We didn't have 500,000 channels to watch. We didn't have information at our fingertips. So it was hard to um, get information, proper information spread. And you know, bad information or gossip always spreads very quickly. So let's talk about some lifespan considerations when we talk about HIV. So older adults with HIV. So in 2013, people who were 50 and older accounted for 42% of all in the US who was living with AIDS. And you think, you know, we wouldn't think of older Americans living with AIDS, but you have to think about a couple things. Number one, HIV is now a chronic disease, okay? So depending on when they were infected, then they have been living with this chronic disease that is manageable with medications, and so they're getting older. The other thing is, and so this is just kind of what this second statement says here, okay? It's a chronic disease. And a chronic disease is something that you have always, but you treat it with medication, you treat it with different things in order to live longer. So think of it just like diabetes, right? Diabetes, we would treat with diet, exercise, and medication, right? AIDS, excuse me, not AIDS, HIV, same thing. Diet, exercise, medication. We want to do those healthy things to treat our chronic disease. So some other reasons, though, that people 50 and above get it is that as we get older, our immune system does decrease. It's not as I mean, we're 50, right? The immune system's 50 years old. So it's not going to be top notch, right? So, which can allow the HIV disease to progress faster, and they can have more complications. But one of the big reasons that they're saying that they do see people 50 and plus being diagnosed is that, you know, nowadays people they get divorced on you know, that's very common, or unfortunately they may lose their spouse, and so they begin to date again, and they may have sex with multiple partners. And this is the thing, if you're 50 and above, okay, what does most people worry about when they're having sex? It's not usually STDs, unfortunately. It's getting pregnant, right? Well, if you're 50 and above, you're probably in menopause. and you don't have a reason to worry about getting pregnant. So they're more likely to have unprotected sex. Okay, so this is going to put them at a higher risk of being transmitted, of HIV being transmitted to them. And then also in the female, as the female gets older, the vaginal tissue may increase their risk for acquiring HIV. And the reason why, okay, and I'm a person, I always want to make sure you understand the why. And as a student, when you move into nursing school, you want to always think about the why of everything. Okay. And the reason why is that as a woman ages, especially when she hits menopause, her vaginal tissue becomes drier. Okay. And so it's going to become doing intercourse, that tissue can tear a little easier. Okay. It can have micro tears in there, which is going to be a opening or a portal of entry for that HIV disease. So strains of HIV. So discovery of a second strain of HIV was the first clue that HIV could mutate very rapidly. Okay, and rapid mutation has become the trademark of this virus. And that is one of the main reasons why it's so hard to have a vaccine against HIV, because it does mutate so rapidly. And what a mutation is if I have one HIV virus here, okay, and let's say I had a vaccine against it, okay, that could kill this HIV virus, what it can do is change one thing within its RNA, within its virus, and then it would make it a whole new type of HIV virus, okay? So now that old vaccine that worked on this one is not going to work on this one, okay? And remember when we talked about intro the myco, we talked about viruses, bacteria, any of those microorganisms. Remember, they're going to do anything in their power to survive, right? And the way the HIV virus does it is by mutating. So you have HIV type 1, and it's found worldwide. It's more prevalent, which means it's more I hate to say popular, but it's more, we're going to see it more, and it's much more virulent. Okay, so it's a toxic strain. So remember in the first two PowerPoints, in the first PowerPoint for exam 1, we talked about virulence, right? And that virulence is how strong it is, okay, and how likely it is to cause cause infection. So HIV 1 and HIV type 2 spread in the same ways and have similar signs and symptoms, okay? So it doesn't really matter if you have strain 1 or 2, okay? They're going to spread in the same way. The I'll get it out. The reason why I need to test to see which one you have is because the treatment is going to vary depending on if you have type 1, HIV 1, or HIV 2. Okay. Both of these viral strains do result ultimately in opportunistic infections when it progresses to AIDS. But this is the thing. If someone has HIV and they take the medication, they take their antiretroviral medication treatment, they can live forever without it ever progressing to AIDS, okay? So let's talk about the 3 stages of AIDS. So we have all right, so we have stage 1. So this is the acute HIV infection. So this occurs within 2 to 4 weeks of infection, okay? So let's say someone has unprotected sex with someone who is HIV positive, okay? Within 2 to 4 weeks of that unprotected sex, that person will start to have flu-like symptoms, okay? fever, chills, body aches. Just think about if you've ever had the flu. What did you feel like? You kind of feel like crap, right? I got the flu. I got something. I'm coming down with something. Okay. That's what people feel like. Then during this time, they are very infectious, okay, which means they can spread the virus very easily, okay. The reason why they're so infectious during this time is because they have elevated numbers of virus in the blood and the body fluid. So what happens during this time frame, the body has not, the immune system has not really started to attack it yet. And it's because of the way that the HIV virus enters our cells. And we're going to talk about that in a moment. So at this point, it's taking over, our HIV is taking over our CD4 cells, okay? And they're reproducing very, very, very rapidly because our immune system hasn't started to attack it yet. Once the immune system realizes what's going on, okay, then it's going to start suppressing the making of the viruses, okay? This is where we get into stage 2, which is the chronic HIV stage. In this stage, they're often asymptomatic. So if you are sympathetic, if you I can't even say it now, symptomatic. So this is when you don't have symptoms, okay? So if you do have symptoms, okay, um, then you have symptoms. But if it puts that A in front of it, remember that A means without or none or no, okay? So you're often asymptomatic. So you're not having any symptoms, okay? And this is where we said that they have low levels of virus in the blood because our immune system at this point has discovered that, hey, something's going on here, and it is trying to keeping it at bay. So the virus reproduces very slowly. And this stage can take 10 years or longer without medication. Okay. So if someone doesn't know that they have it and they're not on medication, then they can stay in this stage for about 10 years of longer. And remember, this is going to vary from person to person, okay? Because everybody's different, okay? Now, with medication, if they are taking antiretroviral medications for HIV, then they can stay in this, they may be able to stay in this stage forever, okay? And never progress to stage 3, which is AIDS. So at the end of stage 2, they do start to become symptomatic, which means that they're going to start showing some symptoms of early symptoms of HIV. So stage 3, this is when they have developed AIDS. Okay, so now their diagnosis is no longer HIV. Their diagnosis is now AIDS. So this is the most severe stage, and this is when they start to develop opportunistic infections because their immune system has been damaged. So what an opportunistic infection is anything that's laying dormant in the body, whether it's good bacteria, whether it's bad bacteria, and it's just waiting for the opportunity to be able to grow and flourish and cause disease. So this is the viral load at this point is very elevated. Okay. So what happens when it gets to stage 3 is that your immune system has been, or the HIV patient's immune system has been fighting the HIV virus to keep it at keep it down for so long that now the immune system is just exhausted, okay? And it can no longer fight. And so since it can no longer fight, that virus is reproducing and reproducing and reproducing because it doesn't have the immune system to hold it down, okay? You are very, very, very contagious at this point. So in order to qualify for AIDS, to progress on to that AIDS diagnosis, the patient's CD4 count has to be less than 200 cells per millimeter. So we're going to talk about in some future slides in depth exactly what CD4 means, what that cell count means, what's the normal count, etc. But just know for AIDS, they have to have that CD4 count less than 200, and they have to be having opportunistic infections, okay? So some symptoms of AIDS is going to be fever and chills, swollen lymph nodes, weight loss, weakness, chronic diarrhea, and night sweats. All right, so there were some trends that began in 1996 with the use of highly active antiretroviral therapy. And this greatly increased among people with HIV, and this allowed people with HIV to live longer, okay? It allowed them to live and not progress to AIDS, or if they did progress to AIDS, they were able to live a lot longer than just the 10 years. So since that time, fewer people have developed AIDS. So if the person who is diagnosed truly takes on responsibility of accountability of the treatment that they need to do, again, they can live a very long time without transitioning or progressing to AIDS. So art art therapy is what they call it, okay? So art stands for anti, okay, which means against, and retroviral. AIDS is HIV is a retrovirus, okay? So if it's an antiretroviral, that just means it's against that retrovirus, okay? So antiretroviral therapy. So you risk some risk factors related to transmission. So men who have sex with other men, and they abbreviate that, or the acronym for that is MSM, comprises the biggest proportion of HIV and AIDS patients. So the reasoning behind this is that most people or most men who have sex with men, the person who is on the receiving end, and they usually have anal intercourse, the anus is a lot tighter and it's not as lubricated, okay? So it's more likely to tear. And so those micro tears within that area is going to allow for more of the virus to enter within to the body and into get into the bloodstream. So Hispanics and African Americans have been disproportionately infected with HIV. And the belief behind this is due to the Hispanics. They believe that most of the undocumented Hispanics, they're reluctant to seek care because they don't want to be deported. Okay, they don't want to be reported as being undocumented. Also, there's a language barrier that increases difficulty to find care, okay, if you don't have doctors and places that speak their language. Also, with the African Americans, it is believed part of it is due that most African Americans deny men who have if they have sex with other men, they usually deny that because they don't want to be looked at as gay, and they resist to get, and in addition to that, most African Americans resist to get care. It says African American adults and adolescents are 10 times more likely to be diagnosed with AIDS than Caucasian adult and adolescence. So remember, AIDS, you're going to progress on to AIDS if you're not getting the treatment or not following the treatment, right? And if they're resistant to get care, then they're likely to develop HIV because they're not taking the antiretrovirals. Okay, so um, moving on with HIV transmission. So conditions that affect the likelihood of infection. So it's going to depend on the amount of virus inoculated into the recipient, excuse me. So what does that mean? Inoculated just means inserted or put in, okay? So if you're having sex, you're having unprotected sex with someone who has HIV, it's going to depend on where they are within those HIV stages. If they're in that beginning stage when that HIV virus load is really high, or if they're at that stage of AIDS when it's really high, then you're more likely to get infected. If they're in that chronic stage, you can still get infected, but there's a possibility that you necessarily won't because the viral load is not as high. So it also depends on the infectiousness of the virus. Again, the virulence. We learned about that in the first PowerPoint. Also, the susceptibility of the uninfected person, okay? Is their immune system down? Do they have, does anything going on that has their susceptibility down? Are they a drug user, okay? Are they a patient getting chemo or radiation? Is there a nutrition bad? Okay, so anything that can decrease or increase their susceptibility. Also, in the duration and frequency of exposure, if you just have one exposure, you may not necessarily get it, but if you're having repeated exposure to the HIV virus, then you are more likely to get it. So some ways that HIV is not spread, okay? It's not spread by air or water. It's not spread such as by insects such as mosquitoes. So again, back in the 80s, that was one of the big things, and you were scared to death because we live in Louisiana. In the summertime, there is a lot of mosquitoes. And the thing is that they said if the mosquito bit someone with HIV and then bit you, it could pass it on. That is not true. Okay. But again, in a time where we had so much misinformation or unknown information, that was a big fear. Also, it cannot be spread by saliva, tears, or sweat. Casual contact, such as shaking hands, sharing dishes, or closed mouth kissing. So, social kissing. So, if you just walk up and give somebody a peck or peck on their cheek, anything like that, it cannot be spread that way. So, some ways that it is, hold on a second, let me see something. Let me just say something right here on this one. Open mouth, deep open mouth kissing, okay, with someone who either has an open cut, bleeding gums, or ulcers in their mouth and they have HIV. If those two people have that and they're doing open mouth kissing, it can be transferred that way. Okay. But both people have to have openings, one uh to be able to transfer it. Okay. Oops. So HIV is transmitted from human to human through infected blood, semen, rectal secretions, cervical co-vaginal secretions, and that's just the female vagina area, okay? The end of the cervix in there, the vaginal tissue in there, and then breast milk. So HIV is also found in pericardial fluid, which is the fluid around the cardio area. Synovial fluid, that's your fluids in your joints. Cerebral spinal fluid, that's the fluid around your spinal cord. Peritoneal fluid, that's the fluid within your abdominal cavity. And amniotic fluid, that's the fluid that the fetus lives and grows. So let's talk about vertical transmission. Okay, so when we talk about vertical transmission, that is transmission from the mother to the baby. Okay, and so vertical um, transmission can occur during pregnancy. Okay, because think about the mother and the infant's baby, the baby's blood is mixing, right? And if the mother's blood has HIV, then the baby can be HIV positive. Also through delivery. Okay, so if the mama is given having vaginal delivery, the baby can come in contact with the mama's blood, secretions, things like that can go into the baby's eyes, mouth, anything like that during delivery. And then through postpartum breastfeeding, okay, so the HIV virus is within breast milk. So just all right, so just a couple things that's not on the slide here. So you want to make sure, and I think it's part of all processes now, is that moms who are pregnant are being tested for HIV to make sure that they don't have it. And if they do, they can be on retroviral medications to help decrease the chance of transmission to the fetus. Also, if they know that they're HIV positive, then they're going to do a C-section at delivery versus a vaginal delivery. And then through postpartum breastfeeding, if you have HIV, would you want to breastfeed? No, okay? Even though it's the best for our baby, if you're HIV positive, you do not want to continue to um, um, give HIV infected milk to your baby. So they would be fed through formula. So the two most common modes of HIV transmission is anal or vaginal intercourse, contaminated drug injection equipment, and paraphernalia. So what do we mean by drug injection equipment and paraphernalia? What that means is anything that drug addicts use to mix their medications, draw up their medications, and give it. So it could be uh, the syringe or the needle itself. It could be the spoon that they cook it with, okay? Because that spoon's gonna can have the contaminated liquid in it from the needles and the injections. So anything like that. It's not just about just using the syringe or using the needle. It's anything that they're using to mix that medication. It's not medication. I'm sorry, to mix that drug, to draw up that drug, to cook that drug. Okay. So sexual intercourse remains the most common mode of transmission. So again, HIV is spread primarily by not using a condom when having sex with someone with HIV. Unprotected anal sex is riskier than unprotected vaginal sex. And the reason why is I mentioned that on the prior slide or so about it being tighter and less lubrication there. So it's going to tear more easily. Okay. Again, among men who have sex with other men, the unprotected receptive anal sex is riskier than unprotected insertive sex. So what they're saying there is the person who is receiving, um, I'm trying to think of a professional way to say this. So it's not the person who is that's inserting, is the one who's receiving the insertion, okay? They are more at risk. Also, having multiple sex partners or the presence of other sexually transmitted diseases. So, if a person has other sexual transmitted diseases, whether it's let's see, herpes, gonorrhea, or syphilis, anything like that that could be causing open sores or irritation or anything like that within the sexual area, then if they have those sores or openings from another STD, then they're more likely, if they have sex with a person with HIV, that HIV can enter more easily through those open areas. Unprotected oral sex can also carry risk of HIV transmission. but it's much lower risk than the anal or vaginal. And the main thing with the unprotected oral sex is more about if they have those open sores, if they have bleeding gums, if they have irritated area in the mouth. Again, that's going to be an easier route for the infection to enter. Sharing needles, syringes, rinsed water, or other equipment used to prepare illegal drugs for injections. So that's kind of what I spoke about on the prior page. All right, so some less common modes of infection. So being stuck with an HIV contaminated needle or other sharp items. This risk pertains mainly to the healthcare worker. So healthcare workers have to be very conscious and very careful, and not just with the patients that we do know have HIV or AIDS, right? We have to really um, treat every patient as they're infected, because we really don't know, because that person may not know. Okay, so we have to treat everybody as being infected, so we have to be very careful with needles and sharps. Also, receiving blood transfusion, blood products, or organs or tissue transplants that are contaminated with the HIV virus. This is an extremely remote risk. And what they mean by extremely remote, which means very, very small, unlikely way, okay? Because everything is tested nowadays, and we're going to talk about that, okay? Unsafe or unsanitary injections or other medical or dental practices. This risk is also remote with the current safety standards in the US. And so back before HIV, they didn't necessarily have those standard safety practices, right? Those safety precautions before the 80s. Okay. So it was more at risk for medical or dental practices to get infected, but not anymore due to those standard safety practices. So, eating food that has been pre chewed by an HIV infected person. This one always grosses me out. Okay. So this is more about, you don't really hear this as much anymore, but God, I guess about 10, 15 years plus years ago, the big thing was is that parents, instead of buying baby food, they would get food, they would chew it up, then take it out and feed it to their infant. Okay. So this is a way that it can be transmitted, but it's a less common mode. Being bitten by a person with HIV, it's less likely unless the skin is broken, okay, but it's still less common. And then this is the French or deep open mouth kissing that I was speaking of just now. So with an HIV infected person, if the HIV infected person has mouth or gum or bleeding or open sores in the person that they're kissing, then you can have that transmission there, but it's very unlikely. So blood and blood products. Since 1985, blood, blank, blood, blood banks in the U.S. have screened all donated blood for HIV-1 antibodies, okay, because this is all they knew about. In 1992, they also screened for HIV-2. Blood from donors who are deemed high risk or who test positive for HIV is discarded. So they test all the blood if it tests positive. Also, if you've ever given blood, there's this little form that you have to fill out beforehand and then ask you certain things like, have you been out of the country recently? Have you had unprotected sex with someone known to have HIV? Do you have sex with the same gender? Okay. Those are considered high risk donors. In addition to testing the blood for HIV, there's also several other screenings that they do. You don't necessarily have to know these for the test, but just be mindful of what all they test the blood for. Okay, so HIV 1 and 2, the HTLV1 virus, HTLV2 virus, also hepatitis B, West Nile virus, T. cruzi virus, and hepatitis C virus. Okay. So blood now, when it's being donated, it is tested for all of these viruses. Now, one thing to be aware of is that even though they test all of these, there is a very slim or remote chance that a product can still have a risk, okay? Because if they're in that window yet that they have not developed the antibodies, then it will not show up. So occupational exposure to HIV. So about or almost 25,000 adults who developed AIDS before 2003, so that's been 21 years ago, were healthcare workers, okay? Because at the time, they didn't really know about the disease. They didn't know in the beginning how it was transferred. A lot of people acquired it before all the safety precautions were put in. So this represented 5% of all AIDS cases among adults who had a known occupation. And so a known occupation, that's going to be things such as doctors, nurses, paramedics, EMTs, first responders, those types of people that deal with blood and guts and secretions and things like that on a regular basis. So in 2019, or 2019, in the US, only 58 healthcare workers were infected with HIV. So between 2003 and 2019, so before that, there was 25,000 occupational um, um, cases. Now, in 2019, there was only 58. Okay. So that's a huge drop, right? And that's because of the standard precautions that's been put in place and that um, the healthcare workers are following those precautions. Okay. All the precautions in the world can be put in place and policies can be put in place. But if everyone doesn't follow them, or if the person doesn't follow them, then it's going to put them at risk for some type of injury. So most of the healthcare workers who have been infected with HIV are nurses. And why do you think that? Because we're the bedside nurse, right? We're the hands-on. We're touching the patients and doing treatments to patients and changing patients and we're doing the injections and the IV starts and all of those things that's going to put us in constant contact with blood and body secretions and fluids. The risk of an exposure to HIV from a needle stick injury is less than 1%, and transmission by direct skin contact with fluid is less than 0.1%. All right, so very low transmission rate there. So post-exposure prophylactic, which is PEP, is an antiretroviral. It can be used to treat possible let me just finish reading this first. Sorry. But it can be used, but they're hepatic toxic, which results in severe hepatitis that may necessitate liver transplantation. So pretty much what this is trying to say is that if you do have a needle stick, okay, there is this PEP, which is an antiretroviral regimen that they can give you to keep you from being infected with the HIV virus from that infected needle stick. The issue is that you have to weigh the pros and cons with your doctor because it can be hepatic toxic, which means that hepato, I can't talk today, sorry, means liver. And then of course, toxic means it's a bad thing. It can cause damage. So it can be toxic to the liver. And so you want to make sure that you discuss the pros and cons with your doctor because it can cause some long-term issues, including the need for a liver transplant, okay? So perinatal transmission. So again, this is the one that we talked about earlier. This is our vertical transmission, right? So perinatal means around. So peri means around, and then natal means like pregnancy. So it's around pregnancy, right? So in the US, it's estimated that approximately 25% of infected mothers will transmit HIV to their infants. Another 50 to 70% of the transmissions occur late in utero or during birth. So it just means late in utero, just means late. So utero means in the uterus, okay, is where your baby's growing. So it's late in that pregnancy or during birth. And we talked about already how the baby can not collect it, be transmitted with it within the delivery. So it's the most common way for children to be infected with HIV is perinatal through the vertical transmission. HIV transmission rates from mother to child has been reduced because of interventions, including ART therapy, formula feedings, and cesarean sections or your C-sections. So as I talked about with the earlier discussion, is that if they know that they have HIV, then they're going to do the C-section. That way the baby is not passing through the mama's birth canal. You're going to formula feed, right? Because you don't want to give them the infected breast milk. Also, you're going to take your anti or your ART treatment during pregnancy. So remember, ART stands for antiretroviral therapy. So risk factors that increase the risk of transmission during delivery. So extreme prematurity. So think about if a baby is premature, is their immune system, is their body system, is any of their body organs and everything fully developed to the standards of what it needs to be at birth? No. Lack of health care. So a lot of times with the transmission doing delivery and such is because the mama may not have gotten any health care during pregnancy. And so one, she may not have knew she had HIV, okay? Or two, she may have known, but still didn't get care and it can be transferred to the baby because normally if they have lack of health care, when they go into delivery, they usually either deliver at home, okay, or maybe call 911 and go to the hospital and deliver either in the ambulance or at the hospital. So gestational complications that lead to extended labor, labor that mixes of the maternal and the fetal blood. So any types of complications within the pregnancy or during the pregnancy can put them at higher risk. Also, the newborn ingestion of the maternal blood, amniotic fluid, or vaginal secretions during delivery, skin excoriations in the newborn. And so if you've ever seen a newborn, you know, their skin is dry, it can be irritated. It's not beautiful, soft, you know, skin. Being the first child born in a multiple gestation. Okay, so that first child that's being born through is usually going to be the one to get the most secretions and things like that. So pathophysiology of HIV. So that is going to be the patho is kind of how it works, and the physiology is how it works. The patho is the details of that. Okay. HIV is classified as a slow retroviral virus. So remember, we said that the patient is going to take an antiretroviral, right? Because it's an anti to be against the retrovirus, okay? And it's a slow retrovirus because remember, we said in that second stage, that chronic stage there, they can be in that stage with that HIV virus growing for about 10 years, right? Without treatment. After infection with these types of viruses, a long time passes before the specific signs and symptoms appear. Okay, and it's just kind of repeating what I just said. That means that's that slow part, right? It's also an obligate virus, okay? And hopefully you remember from test one what an obligate virus is. And that means that it needs a host organism to survive. So the virus can't live outside the body on its own. The virus is going to take over the host cell, and it's going to reproduce viral copies of it. Okay. And we're going to talk about in detail those steps that the DNA, that the virus does to take over the human body cells. So the virus, again, it has to be incorporated into that host genetic cell material in order to reproduce its own cells. Retroviruses are made up of RNA. And this is important because when we talk about how HIV virus enters the cell and takes over the cell, you're going to realize really how smart, how extremely smart the HIV virus is. Okay. So most organism genetic material is made up of DNA. So retroviruses use reverse transcriptase, an enzyme to make its RNA change to DNA. So this is where we get into the really how complicated, in addition to smart, the HIV virus is because when it enters our CD4 cell, okay, in the body, attaches and enters, it's going to put its genetic material, which is RNA, into there. But guess what? Human cells have DNA. So it can't incorporate its RNA into that DNA, okay? But it's going to have to in order to take care over the cell. So what it does is it releases this reverse transcriptase enzyme, and it changes its RNA into DNA so it can sneak in and incorporate into our cell's DNA. Okay. So this is how it's able to get our DNA in our cells to replicate its genetic material. So we're going to talk about first not first, but we're going to talk about the HIV life cycle. So the first step, actually, hold on one second. Let me do something. We'll pull up another sheet. All right, so we'll pull up, where's my picture? Here it is. Okay. All right. So I'm going to share the HIV life cycle picture, and I'm going to lecture from the picture. Okay. And okay, so this is the overall picture right here that I'm going to be lecturing from. I have uploaded this full picture under your exam 2 information in your modules. Okay, so the slides that are going to go along with this is going to be slides 20 through 23, it looks like. So, okay. So when we look at this, okay, so now I'm going to go ahead and blow this up. All right, so when you're studying, you want to when you're studying those slides, you really probably want to try to print this out and study this along with those PowerPoints, okay? We're also going to use this picture when we talk about the antiretroviral medications, okay? So our HIV life cycle. So the first step, okay, is going to be the binding, okay? This is also called attachment, okay? So this is so remember on the very first PowerPoint, we had this picture right here. This is our HIV virus, okay? And if you see, it's got all these little receptor things that are kind of poking off of it, okay? This is what is used to bind to the receptors on the CD4 cell, okay? The CD4 cell or the T cell is one of the main cells that is part of our immune system, okay? So HIV is floating around and it's looking for the specific cells, okay? It's not going to attach to any other cell, okay? The cell that the CD4 cell, okay, this is the cell membrane of it, it's got these receptors, and this HIV virus connects right there perfectly to that receptor, okay? So once it binds to that receptor, then it's going to move on to the second step. Now, what I do want to point out right here is each of these little things that says stop, okay? This is the type of drug that will stop the HIV virus at this point, okay? So if the patient is on a CCR5 antagonist or a post-attachment inhibitor medication, it's going to stop this from happening, okay? So it's a way to prevent the HIV cell from attaching to the CD4 cell, okay? So the next thing is going to be the fusion, okay? So when we look at fusion, this is going to be where the HIV envelope and the CD4 cell membrane fuse together, okay? They fuse or join together, which allows the HIV to enter the CD4 cell. So this is where it attached, okay? After it attaches, it fuses with your CD4 cell membrane. This is your CD4 membrane right here, okay? So now the HIV virus is fusing within that membrane, okay? That's the second step. And if your patient is on a fusion inhibitor, this is going to stop the cell from fusing, okay? So even if the cell made it to this point and it attached, it's not going to allow, it's going to block or inhibit it from fusing, okay? So then we're going to go to the third step, okay, of the HIV life cycle. And this is the reverse transcriptonate, okay? This is the part of just the really how just how smart this virus is, okay? So once it's inside the CD4 cell, okay, so when it fused, it let let me bring that down. So when it infused all their genetic material, that's their RNA genetic material, it released into the cell, okay? Now, what's going to happen is that the HIV releases and uses that reverse transcriptonase HIV enzyme, okay, to convert its RNA genetic material right here, okay, and it's going to convert it into HIV DNA. So your HIV RNA, it takes that reverse transcriptonase right here, and then that allows it to convert it to HIV DNA, okay? This conversion allows the HIV to enter the CD4 cell nucleus and combine with the genetic material called DNA, okay? So remember, any virus needs a host. It's got to be able to have a host, and it takes over cells in that host, and it puts its genetic material in with that host, and then that host, which is usually our own body cells, reproduce that virus now for that virus, okay? It takes over our cell, and our own body cells produces the virus, okay? So the medications that would help block it at this stage, excuse me, is going to be your non-nucleoside reverse transcriptonase inhibitors. And y'all, if something's an inhibitor, it just blocks it or stops it, okay? It's inhibiting it from happening. It's stopping it from happening, okay? The next is going to be the nucleoside reverse transcriptionase inhibitors, okay? So if your patient is on this drug, it's going to stop this from happening. So if it got paid, if the sorry, HIV virus got past step 1, the binding and attachment. It made it pass and it fused, okay? Then hopefully the medication would stop it at this point, okay? Then as we move on to stage 4 or step 4, okay? Now, this right here, this blue part, that's the membrane of the CD4 cell's nucleus, okay? So this is where integration is going to happen, okay? So the inside of the CD4 cell nucleus, the HIV releases integrase and HIV enzyme. The HIV uses integrase to insert or integrate its viral DNA into the DNA of the CD4 count. So what that is saying is, once this happens here, okay, that reverse transcriptase now changed it to that HIV DNA, then that HIV DNA now is entering into that CD4 count, excuse me, CD4 cell. Once it's in that CD4 cell, the HIV virus is going to release this integrase here, which is going to allow it to, this blue part here is the DNA of the CD4 cell. It's going to allow it to integrate or add itself in or mix its DNA in with the DNA of that CD4 cell. So, I want to show you something. Anything, y'all, that ends in ASE, okay? See how we had reverse transcriptase, ASE? We have integrase here, ASE. That ASE means it's an enzyme, okay? And you're going to need, that's very important to know because you're going to talk about many, many enzymes throughout your nursing education, okay? Once you get into nursing school, okay? So anytime you see that ASE on any of these, that means that is a enzyme, okay? So once we make it past step 4, then we go to step 5. And that step 5 is going to be replication, okay? So once it's integrated into that CD4 DNA, which is what happened right here, okay? The HIV begins to use the machinery of the CD4 cell to make long chains of HIV proteins. So remember, this is allowing now, since the HIV has integrated itself into our DNA, now every time we replicate, every time the CD4 cell replicates its DNA, it's also replicating the HIV DNA. So the protein chains are the building blocks of HIV, okay? So these long HIV protein cells is the building blocks of the HIV. And when you get to nutrition, you're going to learn that in proteins in our body is the building blocks of our body, okay? So the HIV protein is the building blocks of the HIV virus. So this is replication, okay? So now, and y'all, I realized last night when I was making PowerPoint copies that I did not put PowerPoint, I did not put 6 assembly in the PowerPoint. And so you'll need to make a note of this, write it somewhere, or print out this picture. Make sure you put a mark there. You will need to know about assembly. I just didn't realize that I didn't put it on the PowerPoint, okay? All right, so assembling. So this is when the new HIV protein and the HIV RNA moves to the surface of the cell and assembles into immature, non-infectious HIV, okay? So it's taking its viral proteins and it's taking its RNA, HIV RNA, the HIV proteins, and it's assembling it together, okay? And it's putting it into a new HIV cell, okay? So it's building a new cell with all the material that it needs, okay? Then when we get to number 7, this is going to be the last step or stage of the HIV life cycle. And this is going to be the budding stage, okay? This is when the newly formed, immature, non-infectious HIV pushes itself out of the host CD4 cell, okay? So it's gotten all the content that it needs now. It puts it back into the shell of the HIV cell, and it pushes it out. So it buds off and it just shoots out, okay? Think of it like if you've ever played with a Nerf, not a Nerf gun. Uh, that's okay. I'm about to show my age. If you've ever used one of those guns that's got the like the ping pongs in it and you shoot them at each other and it just pops out, right? That's what budding is. The little gun thing would be your CD4 cell, and the ball that would pop out would be your HIV infected cell. So the new cell releases HIV protease. Okay, remember we said it ends in that ASE, right? That's a enzyme. So that HIV enzyme, that protease acts to break up the long protein chains that form the immature viruses. The smaller HIV proteins combine to form mature infectious HIV. Okay, so now at this stage, if you want, if the patient is on a protease inhibitor, they're on a PI, it's going to inhibit this from happening. Okay, so it's going to prevent the smaller chains of infection, smallest change of HIV from assimilating, okay? And then over here on the integrase, I think I forgot to say this one, but when we talk about the integration, the medications that would stop integration from happening would be the integrase inhibitors, okay? All right, don't forget again, this number 6, you mean to make a note. Even if you don't print this out, make a note on your PowerPoint or in your notes or however you're setting up your study material that with this content on there, okay? All right, so now I'm gonna stop sharing this PowerPoint. Oh, not PowerPoint, but picture, and let's go back to our PowerPoint. There we go. All right, so, PowerPoint. There we go. All right, so I'm just going to scroll through these PowerPoints that we just went over. Okay, so now we're on PowerPoint 24, and we're going to talk about HIV disease. So HIV disease is when HIV enters the body under favorable conditions, and it multiplies. And as it multiplies, it's producing injuries within the body or within the host. So it encompasses the immune system's progression, dysfunction that is produced by the viral activity within the host. Okay, so pretty much what that is saying is that as it progresses, okay, it's going to affect the host immune system, and it's going to cause it not to function properly. Okay, and so as the immune system is not functioning properly, then it's going to allow for more virus to be produced. Okay. Then we have AIDS, which is the acronym for Acquired Immunodeficiency Syndrome. And this occurs as the disease progresses and the body is damaged severely by opportunistic infections. Okay. And remember earlier we said opportunistic infections is those infections that's just waiting for the right opportunity to rear its head and cause a problem. Okay. End stage HIV. It's also called the end stage of HIV, but most people call it AIDS. And this is when, remember I said the CD4 counts needs to be less than what for AIDS? So remember, less than, well, 200 or less, okay? So CD4 count, 200 or less, is going to mean that the patient is now HIV positive. So this is when the host body can no longer protect itself from injury. Okay. So remember, I said earlier when I was talking about the stages, this is where in stage 2, the body's immune system has worked constantly to keep the virus at bay, and it's exhausted itself. And so now it can no longer protect itself against injury. So let's talk about the function of the immune system, okay? So the immune system, it protects the body from adverse effects of invasions of microorganisms and other foreign substances. They regulate the removal of damaged cells and dispose of abnormal cells that arise within the body. So this video that I have right below here is going to be, it's really important to watch this video. It's going to really break down those key components of the immune system and how they work to keep our immune system functioning, and what different aspects of the immune system and how they work. And you not only need to know that for the function of how HIV functions in the body or what HIV attacks, but you also need to know that for other courses. You know what? I think I'm going to just go ahead and play this video within this video. So let me do this. Let me stop sharing. Okay. Okay, so that video is posted, the link's under exam 2, but we're going to go ahead and show it within this video. Oops. Trying to do share screen. All right, there we go.
Every second of your life, you are under attack. Billions of bacteria, viruses, and fungi are trying to make you their home. So our bodies have developed a super complex little army with guards, soldiers, intelligence, weapons factories, and communicators to protect you from, well, dying. For this video, let's assume the immune system has 12 different jobs. For example, kill enemies, communicate, etc. And it has 21 different cells and 2 protein forces. These cells have up to 4 different jobs. Let's assign them. Here are the interactions. Now, let's make this understandable. First of all, let's add colors to the jobs. Now, let's illustrate the cells. The central color represents the main job of the cell, while the surrounding ones represent secondary duties. Now, the immune system looks like this. Now, the interactions. Isn't this complexity just awesome? For this video, we will only talk about these cells and ignore the rest. So what happens in the case of an infection? It's a beautiful day when suddenly a wild rusty nail appears and you cut yourself. The first barrier of the immune system is breached, your skin. Nearby bacteria seize on the opportunity and enter your wound. They start using up the body's resources and double their numbers about every 20 minutes. At first, they fly under the radar, but when a certain bacteria population is reached, they change their behavior and start to damage the body by changing the environment around them. The immune system has to stop them as fast as possible. First of all, your guard cells, known as macrophages, intervene. They are huge cells that guard every border region of the body. Most of the time, they alone can suffocate an attack because they can devour up to 100 intruders each. They swallow the intruder whole and trap it inside a membrane. Then the enemy gets broken down by enzymes and is killed. On top of that, they cause inflammation by ordering the blood vessels to release water into the battlefield, so fighting becomes easier. You notice this as a very mild swelling. When the macrophages fight for too long, they call in heavy backup by releasing messenger proteins that communicate location and urgency. Neutrophils leave their patrol routes in the blood and move to the battlefield. The neutrophils fight so furiously that they kill healthy cells in the process. On top of that, they generate barriers that trap and kill the bacteria. They are indeed so deadly that they evolved to commit suicide after 5 days to prevent them from causing too much damage. If this is not enough to stop the invasion, the brain of the immune system kicks in. The dendritic cell gets active. It reacts to the signals of the soldiers and starts collecting samples from the enemies. They rip them into pieces and present the parts on their outer layer. Now, the dendritic cell makes a crucial decision. Should they call for antivirus forces that eradicate infected body cells or an army of bacteria killers? In this case, antibacteria forces are necessary. It then travels to the closest lymph node in about a day. Here, billions of helper and killer T cells are waiting to be activated. When T cells are born, they go through a difficult and complicated training process, and only a quarter survives. The surviving cells are equipped with a specific setup. And the dendritic cell is on its way looking for a helper T cell with a setup that's just right. It's looking for a helper T cell that can bind to the parts of the intruders which the dendritic cell has presented on its membrane. When it finally finds one, a chain reaction takes place. The helper T cell is activated. It quickly duplicates thousands of times. Some become memory T cells that stay in the lymph node and will make you practically immune against this enemy. Some travel to the field of battle to help out. And the third group goes on to travel to the center of the lymph node to activate a very powerful weapons factory. Like the T cells, they're born with a specific setup. And when a B cell and a T cell with the same setup meet, hell breaks loose. The B cell duplicates rapidly and starts producing millions of little weapons. They work so hard that they would literally die from exhaustion very fast. Here, helper T cells play another important role. They stimulate the hard-working factories and tell them, "Don't die yet, we still need you. Keep going." This also ensures that the factories die if the infection is over, so the body doesn't waste energy or hurt itself. But what is produced by the B cells? You've heard of them, of course, antibodies. Little proteins that are engineered to bind to the surface of the specific intruder. There are even different kinds of antibodies that have slightly different jobs. The helper T cells tell the plasma cells which type is needed the most in this particular invasion. Millions of them flood the blood and saturate the body. Meanwhile, at the site of infection, the situation is getting dire. The intruders have multiplied in number and start hurting the body. Guard and attack cells fight hard, but also die in the process. Helper T cells support them by ordering them to be more aggressive and to stay alive longer. But without help, they can't overwhelm the bacteria. But now the second line of defense arrives. Billions of antibodies flood the battlefield and disable lots of the intruders, rendering them helpless or killing them in the process. They also stun the bacteria and make them an easy target. Their back is built to connect to killer cells, so they can connect and kill the enemy more easily. Macrophages are especially good at gnoming up the bacteria which antibodies have attached to. Now, the balance shifts. In a team effort, the infection is wiped out. At this point, millions of body cells have already died. No big deal, the losses are quickly replenished. Most immune cells are now useless, and without the constant signals, they commit suicide, so as not to waste any resources. But some stay behind, the memory cells. If this enemy is encountered ever again in the future, they will be ready for it and probably kill it before you even notice. This was a very simplified explanation of parts of the immune system at work. Can you imagine how complex this system is? Even at this level, when we ignore so many players and all the chemistry. Life is awfully complicated, but if we take the time to understand it, we always encounter endless wonders and great beauty.
Okay, so as y'all can see, there's a lot that goes on with the immune system, but they broke it down into a very simple way of understanding what those B cells do, the T cells do, the helper cells, how the antibodies are made, things like that. And that is very important to know and understand when you're talking about not only HIV and AIDS, but also in other courses where you start talking about vaccines, infections, and inflammation in general. Okay. So let's move back to our PowerPoint. Right. All right, so when we talk about HIV, which is the human immunodeficiency virus, and AIDS, these both affect the work of the immune system, okay? And so when we're talking about both of these viruses, the number, the system of the body that it affects is going to be that immune system, okay? And then there's a second video down here at the bottom that is also posted within your within your Canvas course. And all right, so we're going to move on and go get back to the PowerPoint. Okay. All right, so we're now on finishing up PowerPoint 25. Okay. All right, so we're going to move on to PowerPoint 26. All right, so the spectrum of the HIV infection. So this is going to talk about the types of white blood cells in their involvement in HIV. And so this is why I wanted to show that video as part of this video, because I wanted to make sure that y'all understood the rows of the neutrophils and the T cells and the cells that are being compromised during an HIV infection. So the neutrophils, so these are important in the inflammatory response, and they're the first line of defense against infection, and they have a short lifespan. So it's important that as the HIV progresses throughout its stages and it starts to destroy or eliminates the neutrophils, that is why your immune system, one of the reasons why your immune system is compromised is because this is the first line of defense. So if you no longer have that first line of defense there within the inflammatory response, then it's going to affect the progression of an infection. And then the role of the T cells in HIV. So they can cause neutropenia, which is going to be white blood cell deficiency. So which just means lower or low white blood cells. So you don't have as many white blood cells as you could or should. And remember in test 1 exam information, we said WBC stands for white blood cells. And this commonly occurs in advanced HIV disease. So then we have the function of the B cells. So they produce antibodies specific to an antigen capable of being stimulated by the T helper cells. And so what that means, as in the prior video, when it talked about producing antibodies against a bacterial microorganisms, this is whenever the immune system realizes that they've come in contact with this before and that the body has antibodies built up against it, then the T helper cells stimulate the B cells to go ahead and released to attack that known invader, okay? So the role of the B cells in HIV. So the B cells are involved in producing a variety of antibodies for a specific immune response against HIV, and they're present throughout the course of the HIV disease. So if the B cells are being responsible for producing various antibodies and they're being destroyed, then the body can no longer possibly produce those antibodies against different microorganisms to be able to fight off infection. So next we have the function of the T cells or the T helper cells. This is also it also can be seen, it can be called CD4 cells or your T4 cells, okay? So they contain CD4 receptors considered the conductor of the immune system because of their secretion of the cytokines, which control most aspects of the immune system. So again, in that video just now, it gave a really good description of how the T cells work and how they're that conductor, okay? So the role of the T cell in HIV. So these are the main cells that are targeted in HIV. So remember when we showed that picture just now with the HIV life cycle, remember we showed that the HIV virus has the proteins that's sticking out of it is specifically connects with that CD4 receptor on that CD4 cell. So the progressive infection generally destroys the available of the T helper cell so that the overall CD4 cell count drops. So remember, we said as HIV progresses in a person who's not taking antiretroviral therapy, that when the HIV virus takes over the CD4 cell, it's destroying that cell. And then so we have less cells within the immune system to be able to fight off infection. So go back and look at that video again that I showed just now. Okay, this one right here, that's right under the function of the immune system. And really pay attention to what it says, how that neutrophils work, how those T cells work, how those B cells work, okay? And kind of bring it all together in your mind of how that works, okay? So let's move on and talk about the spectrum of HIV infection, okay? So again, HIV is an infectious human retrovirus, okay? So it commonly invades the T cells and the B cells that we just talked about, and that you also saw in that video. The T cells are in the lymph nodes where the virus is trapped. And so think about A and P, okay? Where is the lymph nodes? The lymph nodes are throughout the body, right? All the way down throughout the body. So if T cells are in the lymph nodes, and T cells is the main cell that HIV attacks, then HIV is within all of those lymph nodes. Does that make sense? So the virus replicates within the lymph nodes, the lymph system, okay? So you have the lymph nodes, the tissues of the spleen, and the tonsils, okay? That is all of those things or organs are part of the lymph system. So the lymphatic system carries the infection from one site to the other, okay? So that is where the majority of the HIV is replicated, where it is trapped or stored, and how it's carried throughout the body, okay? AIDS is, again, what is our CD4 level going to be? Our CD4 level is going to be 200 or less to be able to qualify or be diagnosed as AIDS. Also, it's going to have the person has to have opportunistic infections. And most of those opportunistic infections are going to be cancer related. And this is going to be what ends up causing their death, not necessarily AIDS, but the opportunistic infections that are related to the AIDS diagnosis, because once they hit AIDS, that CD4 count being so low, they pretty much have no immune system left. Okay. All right. So inflammation, excuse me, not inflammation, influences on viral load and disease progression of HIV. So HIV replicates quickly after it enters the host body. So remember, that first stage of the infection of HIV, right, is when the person doesn't really know that they have AIDS or that they've been infected with the virus of AIDS. And so it can produce billions of copies very rapidly, okay? So it infects the CD4 cells in the lymphatic system, okay? So what we just talked about in the last slide is that where is the CD4 or the T cell? So remember, CD4 and T cells are the same thing, okay? So when you're looking at something that says T cells or something that says CD4 cells, that's the same thing, okay? And if HIV infects the CD4 cells, and we said in the prior slide that they're stored in the lymphatic system, that is why the CD4 and the lymphatic system is the ones that are being infected. Does that make sense? Okay, so there's billions and billions and billions of them being copied and replicated and reproduced, okay, within our own CD4 cells or our own T cells within our body. Those T cells live within the lymphatic system, okay? And remember, the lymphatic system is throughout the body. So the viral load of the host during the early stages of the infection can be extremely high, because remember, that's what I said when we talked about that first stage, is that it's replicating really high because the immune system hasn't figured out quite yet what was going on. And it's taken a minute for that immune system to say, hey, wait a second, something's not right, and start to fight back. Okay. So because that viral load is so high, then it increases the risk of viral transmission to people who are exposed. Now, what do we mean by a viral load? Okay, so a viral load is the number of viruses in the blood. Okay, so this is going to determine how quickly the CD4 cells are being destroyed. Because think about this. If my viral load is high, okay, what is the virus in? The virus is in my CD4 cells, right? So my virus is here. It's entering my CD4 cells here. As it takes over my CD4 cells, it's going to kill off those CD4 cells because it's taken over those cells, right? Taken over that cell's DNA. So that HIV viral load's going to rise. The CD4 count is going to drop. Okay, does that make sense? Yeah, I'm lecturing like I normally lecture in person. So I always say, does that make sense, a lot in class so I can give feedback. So I've been trying not to say that in this video. So I know y'all can't answer me. Does this make sense? I know that y'all can't answer me, but this is the thing. If it doesn't make sense, make a little note. This doesn't make sense. And we can talk about it on the Q&A. All right, so viral load, again, amount of virus that's in the blood, and during this time, the CD4 count is usually low. All right, so severity and progression of infections related to HIV. So the host infection, so if a host infection with other STIs, age, and immune, okay, I see what's, okay. So what this is saying is that what's related to the progression of infection. So if the host has other STIs, which is sexual transmitted infections, you may hear me say STDs because when I was growing up, that's what it was called, a sexual transmitted diseases. So STIs, what their age is, because remember, the older we are, our immune system doesn't work as great as it did when we were young, and then our immune response. Also, our basic host immune defenses. So if the host immune system is not up to par, then they're more susceptible to have a faster progression of the infection. So again, the host can appear healthy even when infected with the virus. So think about someone who has HIV. So think about, the students always give me, well, what about Magic Johnson? He is HIV free. He's no longer has the disease. That's not true. He will always have the HIV virus, but his virus load level may be undetectable. And we're going to talk about that a little bit more as we continue on. So does Michael Jordan look sick? Does he look like he's infected with a virus? No. Okay. And he's been having it since the 80s. So some patients live with the virus for at least 10 years without any treatment and appear healthy. Okay. A lot of people may have it for many years, and because they don't have the symptoms, they don't know until they start getting sick. Okay. And they start having these random infections over and over. So people who use drugs, engage in high-risk sexual behavior, are less likely to employ infection preventive methods. Okay. And what they're saying here is that people who use drugs are less likely to use protection during sex. Okay. So think about it. Sometimes your drug abuse, people may be women who may trade sex for drugs. Okay. The last thing that they're usually worried about is using a condom or protecting themselves. Okay. Also, people who use drugs, especially if it's intravenous or IV or injectable drugs, they don't always use clean needles, clean syringes, clean paraphernalia. Okay. And then those who engage in high risk sexual behavior. Okay. High risk sexual behavior is going to be your men having sex with men, and um, anal sex, and your prostitution, or your women or men who may have sex for money. So poverty, incarceration, immigration status, and co-infection with STIs. So the it says the reason why is because the population of infected individuals, which is the ones we were just talking about above, poverty, incarceration, immigration, co-infections, are unlikely to see testing or treatment when infection is identified. And so this can lead to continued transmission among this population. So remember, immigration status, if they're undocumented, they're less likely to go get assistance or help or treatment because they don't want to be deported. Poverty, sometimes it's just they can't afford it, right? If they get an STD or if they have an issue, they can't afford to go get treatment. Okay. Incarceration, okay, depending on the STD that they have, or the issues that they have, will depend on if they get the treatment or not, or even if they seek treatment for it. All right, so the next PowerPoint is going to talk about kind of those stages more in depth of the HIV virus, from HIV to AIDS. And so we're going to talk about each of these steps. Let me see something. Okay. So we're going to talk about each of these steps. Trying to see where I'm going to stop at for today. Actually, I think we're going to stop right here. Okay. And then video 4, we'll pick up with this slide, and then we'll continue on. As I said before, on exam, for exam 1, video 1 and 2, please write down any questions that we can discuss during Q&A.